So if you're not able to perform the laparoscopic niche resection or the laparoscopic resection of an ectopic pregnancy, the non-tubal ectopic pregnancy, then of course it is also possible to do it by laparotomy or to treat it by MTX. I really would like to ask you all to use this classification to collect more evidence, because if we use this classification, we are able to develop evidence guidelines in the future. And I did not mention, but the classification of the cesarean scar pregnancy are also freely available online, and we developed an e-learning for this. So nichelearning.online, then you can use it. But you can also search on the ISUOG website, and there are publications on how to perform this classification so that you can use this e-learning program. I would like to thank you all, and I'm very happy to answer any questions. And if you have additional questions, you can always send me an email. Thank you very much.
Thank you very much, Judith, for such an enlightening lecture. I think it has dealt with something that's extremely important, the early diagnosis of cesarean scar pregnancies. And that's good also when we consider it in the light of the increasing relevance of the placenta accreta syndrome, because this is likely believed to be the harbinger for such in the later part of the pregnancies. If I may ask, is there any other benefit of doing a volume ultrasound for the diagnosis of these conditions? And then apart from the site, especially of cesarean section scars, apart from the fact that some of them may be protruded into the cavity, are there other prognostic factors that could make one decide if we should go ahead, continue with the pregnancy, or offer the woman a curettage, as you have talked about?
Thank you very much. I think this is a really important question. And the problem is that so far we didn't use all the same classification system. So there is not good evidence to know when a pregnancy, a cesarean scar pregnancy that's protruding towards the uterine cavity, so it's developing normal, in how many cases it will become a placenta precreta. But we do know that a substantial part of these pregnancies end up in a placenta precreta, and therefore may give high risk on the need for hysterectomy after the delivery, and a high risk of massive bleeding. We counsel our patients that there might be a risk if the pregnancy continues, that there might be a risk on placenta precreta and a risk of hysterectomy. And it also depends on the number of future pregnancies that the patients desire. So if she wants to become pregnant after the current pregnancy or wants to have 2 or more children, then it's probably better to terminate the pregnancy and to restore the uterus. But if this is the last pregnancy, then you could consider to continue the pregnancy. However, if it is a type 2 or 3 cesarean scar pregnancy, so when the pregnancy is really crossing the serosal line, then I think then expective management is extremely dangerous, because then you have a very high risk of rupture. So I think it depends on the classification, it depends on the vascularity, and it also depends on the development. So sometimes 1 week later you can see how the pregnancy is developing. And we also know that a substantial part of the pregnancies that are located in a niche end up in a miscarriage anyway.
Great. On the issue of the 3D and 4D scans, any other benefits of using that for diagnosis?
Sorry, one, can you repeat the question?
Use of a 3D ultrasound scan, any other benefits?
I think that it may help you, but I think that most important is if you just make a scan in the 2 directions, so the sagittal plane and the transversal plane, and if you make a clip from left to right and from cervix to fundus, then you're able to identify the localization of the pregnancy. And I think that the use of power Doppler is more important than the use of 3D. But for the interstitial pregnancies, I think it's helpful to make 3D. But you can also diagnose it without 3D.
Yeah, thank you very much. It's also good to emphasize what was said even in the last set of lectures, that most of these diagnoses are by transvaginal scans, and still again addresses the importance of adequate training and competence in the use of transvaginal scans in the diagnosis. I don't think diagnostic accuracy of transabdominal ultrasounds can be as high as for transvaginal scans in these pregnancies. However, I do think that one could start, because you don't know who has that, so you're starting with the transabdominal scan, and once you suspect that there is a non-tubal ectopic, then you could progress to a transvaginal scan to confirm your diagnosis. Is that right?
Yeah, well, in general, we always make transvaginal ultrasounds to assess it, because you get better images. And in particular, if the women have a high BMI, then it's much easier to perform it transvaginally. So if possible, I would advise and encourage everyone to make a transvaginal, but then you of course need a transvaginal probe.
Thanks, Judith. It's been a great time with you today.
Yeah, I mean, I think there's always a sort of, people think that doing a vaginal scan is we never have an issue. I mean, we always start with a vaginal scan. The patients expect it, and it's actually quicker. And interestingly, a lot of patients find it more comfortable than having a full bladder. They often say, I didn't like the idea of it, but it's much better than being told to sit in the waiting room trying to keep my bladder full. I mean, I know that's not the case for everyone, but I think it's pretty well accepted in a place like London, which has a very mixed population from all sorts of, backgrounds. So I think it's, if it's explained, I think it's well accepted as a way to do it. Judith, one of the last question, we've got 1 minute. One of my concerns about in early pregnancy is diagnostic performance and, if you like, not harming pregnancies. And I think I do want to have a view. I don't know what your view is. We see quite a lot of, well, that's because of exaggeration. We do see some people who have been told they have scar pregnancies, and we see them and they haven't. And similarly, we see people who have been referred, to manage their interstitial pregnancy. And of course, you know exactly what I'm going to say, right? They're not exactly there. And in some ways, that's just as big an issue. Gets the misdiagnosis for me, which I suspect is quite, well, not common, but I suspect it's not as rare as we like to think it is. And how do we deal with that? And because obviously you're doing a lot of big trials where I think you're probably one of the few groups which will be able to develop robust diagnostic criteria that stand up with some idea of how the tests perform. How do you see it at the moment?
Well, I think that concerning cesarean scar pregnancy, I think it's easily recognized. But when you're in doubt, then there is no problem with just wait a few days and repeat the ultrasound, because then sometimes it becomes more clear. And if you're in doubt, don't terminate. That's I think very important. And the same accounts for the interstitial pregnancies. The interstitial pregnancies, when you diagnose them, mostly do not rupture so easily. And particularly if they don't have much symptoms, you can just wait and see how it develops, because then it becomes much more clearer. And we also have several examples of an incomplete interstitial pregnancy that just develops and progresses towards the uterine cavity and ended up in a normal term pregnancy. And there were some placental problems, but that could be easily treated. But so be sure that you do not terminate when you're in doubt, and just wait a few days, and sometimes just wait a week and see and ask an expert to join you, or refer the patients to an expert center, and do not terminate if you're not sure. I think that's really important.
Yeah, I mean, I think that's a very good point you make, which it's never harmful to get a second opinion. Even in one's own department, it's good practice to get someone to check a diagnosis of miscarriage. However obvious it may be, I think it's very reassuring that the patient knows two people have checked it for such a big thing in their lives, even though you might be the most experienced person. I think from the patient's point of view or the woman's point of view, I think it's quite reinforcing. But equally, having centres of excellence dealing with these relatively rare or rarer forms of ectopic, I would say is surely probably quite a good idea. I know people like to hang on to their patients, but you know, I think having referral centres makes sense. Just one last question, actually, whilst we're still here, and we've got literally 30 seconds. There's a question from the audience. How do you carry out uterine artery ligation before they put E and C? But I think they mean curettage. And the answer is
no, not for DNC.
no.
Actually, if we see that there's not much vascularity, or if there's no connection, or if it's not crossing the serosal line, then we even do not use a balloon or a temporary cerclage. We reserve that, as you discussed already, after 8 weeks, or if there is a close connection with the uterine vessels, or it's protruding beyond the imaginary serosal line. If we perform a laparoscopic niche resection or a laparoscopic removal of an interstitial pregnancy, then we do combine it with temporary occlusion of the uterine arteries and also the ovarian vessels. And we clamp them with bulldogs and we take them off after the surgery just to reduce the blood loss.
I think, I don't know, Emma Kirk might remember, but I mean, I remember, you know, when I started doing scans, early pregnancy stuff at King's back, you know, back in the 30s. Anyway, no, but cesarean scar pregnancy didn't really exist as an entity, and the section rates weren't that low. But of course they were there. And of course, what happened is, you know, we went to theatre with usually the most junior staff member would take a patient to theatre, and every so often they'd bleed like hell. And undoubtedly, I suspect these were scar pregnancies that were just being completely missed because we weren't looking for them. So, and you know, it was okay, not nice, but I mean, certainly, I think in most certainly early scar pregnancies, they're generally not any more complicated than any kind of straightforward surgical management of miscarriage, actually, for the ones which are early and not even, you know, not approaching the serosal line. But obviously, these are the ones which are least likely to be problems later on, and it's how these behave are the ones that, you know, we don't really know much about. Judith, we could talk for hours. Got to stop and move on to our next speaker. Thank you so much. I know you have loads of commitments, so thank you very much for taking part today. Really appreciate it.
Thank you.
And now I'm going to introduce for the last time today Thierry van den Bosch, who gets the prize for the hardest working speaker on the course. Every time I see you, you're slightly lower in your chair, Thierry, so thank you. That's it. Have a coffee and go for it. And you're going to talk to us about PID and diagnosing it, and possibly the ultrasound guided management of pelvic abscess. So in the context of this audience, I think this is a big subject to cover. So look forward to hearing from you. We'll have a chat later when you've heard the talk.
So thank you for inviting me to say some words about the diagnosis of PID and about the ultrasound and ultrasound guided management of pelvic abscesses. First, about the diagnosis of pelvic inflammatory disease. Well, there are the diagnosis is based on history and symptoms, about lab tests, and about clinical examination and ultrasound. And you see, I put clinical examination and ultrasound in the same bubble, because I think that's one. This ultrasound examination is part of the clinical examination in my view. And we know the signs and the symptoms: adnexal tenderness, cervical excitation, temperature, abnormal discharge, vaginal bleeding, and the the elevated white cell count, elevated sedimentation, elevated CRP. Though I must say, it takes some hours, some days to rise. So if it's not that much elevated, does not mean that it's not a PID. And also you have the culture of Neisseria, gonorrhea, or chlamydia, although quite some PIDs are not caused by one of those bacteria, as I will tell you later on. And obviously, if there is an abscess, you will feel an adnexal mass, but you will also see one. And as to ultrasound, the adnexal tenderness, cervical excitation is more precisely evaluated using a transvaginal ultrasound, more selective to see that's painful, that's not painful. And also for adnexal mass, ultrasound is of course very useful to for the diagnosis. Now, if you think about the pathogenesis of pelvic inflammatory disease and of tuber-ovarian abscess, well, the classical way to have a PID is starts with bacteria vaginal of the vaginal flora, or sometimes normal bacteria of the vaginal flora are more selective pathogens as chlamydia and Neisseria gonorrhea, and these bacteria will go through the cervix and will reach the isthmus and the fallopian tube, and then the infection will climb through the tube, and that's when we talk about salpingitis, and when the patient will have some symptoms of pain, and if you look at ultrasound, you will not see that much, but perhaps you will see that the wall of the fallopian tube is somewhat thicker, but it's not very easy to see, especially if there is not fluid inside yet. But you will probably have this selective tenderness pushing at the corners of the between the fallopian tube and the uterus. You will have selective tenderness, and often it is bilateral, not always, but often it's bilateral. And if the process goes further, well, I have to say first that it's some of the infection are not caused by vaginal and cervical infection, but are caused by other causes such as appendicitis or diverticulitis. And that the fallopian tubes are affected secondary to the bowel disease. That's important, and it's indeed important if you have a patient with pain, especially if it's more lateral to the right side, to think about appendicitis, and also to look using ultrasound, and that vaginal ultrasound. Sometimes you can quite easily see the typical target sign of the appendicitis, or you see a blind ending fluid collection being some pus in the appendix. So it's important to think about that and to look for that, because you can often make the diagnosis using ultrasound. Okay, if you have salpingitis, the infection can progress, and then if it progresses, you will have pus formation in the fallopian tube, and because of the infection, the fimbriae will stick together, and there will be the fluid production, the pus production will be locked in the cavity of the fallopian tube, and the fallopian tube will become swollen, and then you will have what we call a tuber-ovarian complex, being the pyosalpinx, and then adhesion, and you see also adhesion between the salpinx and the ovary. You can using ultrasound, you can still see the swollen fallopian tube, the pyosalpinx. You can see the ovary, but you cannot move they are stuck together, and usually it's also stuck to the uterus too, and to some bowel loops too. So you have a complex where you can see the tube and the ovary separately. And if you wait even longer, then you have what we call a tubo-ovarian abscess, and then you have, in fact, it's using ultrasound very difficult to see where is the ovary, where is the tube. You see a fluid mass, very difficult to delineate, and very tender when you push on it. And that's in fact a big abscess, usually behind at the posterior lateral side of the uterus, and that's an abscess. What's the pathogenesis? What causes that? But well, you have to know that it's a polymicrobic infection. You have different bacteria causing this abscess, and that's also why for the therapy you have to use antibiotics that cover quite some different types of gram-positive, negative bacteria, anaerobic bacteria too. So it's not only the chlamydia and the Neisseria gonorrhea causing PID. No, you have the whole bunch of other bacteria like the E. coli or even the streptococci and Haemophilus. Well, you have and Peptococcus. You have quite some potential pathogens in PID, and you have to think about that when treating it by antibiotics. Important when you have a PID, when you have a tubo-ovarian abscess, if there is concomitant endometriosis, that's potentially more dramatic than if there is no endometrioma beforehand, because probably the blood in the endometrioma may favor the production and the growth of bacteria, or maybe there are other causes too. Also think about, as I just say, about diverticulitis, appendicitis, inflammatory bowel disease that may cause the infection and then goes to the fallopian tubes and the ovaries. And of course, especially in postmenopausal women, if you have a postmenopausal woman with an abscess, think about a potential underlying ovarian cancer. The seminal paper about the ultrasound for PID and tubo-ovarian abscess is by Ilan Timurtrich in the late 90s, and here nicely describe what I just said, these different stages of the disease, starting with the salpingitis, or the thick wall tube becoming a pyosalpinx with the cogwheel sign, and then the tubo-ovarian complex, where you can still see ovary and the tube separately, and then the tubo-ovarian abscess when you see confluent loculation and with speckled inhomogeneous fluid inside and extreme motion tenderness. It's nicely described. I will invite you to read again the paper by Ilan Timurtrich, and there are also nice figures about how a tube evolves during the infection. That's a normal tube with the normal folds of the mucosa. When you have an infection, these folds will stick together, and you will have what he called the cogwheel appearance of the tube, and that's something you can see on ultrasound. And once the infection is cured, everything, the wall will become much thinner, but these fimbriae stuck together will remain, will be smaller, and that's the typical beads on a string sign that you can see when you have a transection of the fallopian tube. And here you see also the different stages of a normal tube becoming a pyosalpinx, and then going to the stage where it will become an abscess and a tubular ovarian abscess. Some here you see a tube here with incomplete septae, thickened wall during a more acute phase of the disease. Here you see the typical beads on the string, and that's in fact a transection at this level of the tube. You see these beads on the string. Something you see, but more after at the end stage of the infection, when the infection is gone. When it's acute, everything is more thickened and more vascularized. Here you see also typical sausage shaped filled hydrosalpinx. You can use 3D and the inverse mode, but you don't need it to have a diagnosis. And here we also see a thickened wall of the fallopian tube and these beads on a string. What's the management of tubular ovarian abscess? Well, it's IV antibiotics to cover all the potential bacteria, and that's the view of Seth Granberg, and I think he's right, and ultrasound guided aspiration if there is abscess as soon as possible. And what are the indications for further surgery using laparoscopy or laparotomy is if you have a rupture of an abscess or bowel perforation, unsuccessful drainage, failure of treatment, if the first treatment fails, or if you're uncertain about diagnosis. What type of antibiotics you need depends on your local protocols, but the Leuven protocol, but there are other protocols. But the thing is, you have to cover all types of potential pathogens, so even anaerobic, gram-positive and negative bacteria. That's important to have a broad spectrum and to give enough. When we talk about the drainage of the aspiration of abscess, I think the first major publication about by Knut Gilland, and I think he was of the pioneers of the aspiration of tubular ovarian abscess, and I also invite you to send this QR code and to read his paper, because it's written by someone who knows what he's thinking about and is on the field, and it's very useful for all those who are working on the field. And in fact, it's transvaginal ultrasound guided procedure, true cut biopsy. We use it for aspirations of cysts, aspirations of abscesses, and just in some words, what do you need? You don't that much. Of course, you need an ultrasound and a vaginal ultrasound probe, and you need a needle guide that's adapted for your ultrasound probe. So you have to go to the company and to ask what is a guide that fits your probe, and of course, you first put some probe cover with some gel, then you apply the needle guide, and then you apply a second probe cover, obviously also with sterile gel, for instance, inside the probe cover. And then you need a needle, the 30 centimeter needle. This is 1.4 outer diameter, but Gilland use 1.6 millimeters. I think the thicker it is, in a way, the best is because pus can be somewhat viscous and difficult to aspirate. So you need a needle, and then needle has a lock end, and what I find easy is to put a 3-way step lock with connection tube here in between. Makes it much more easier to flush, to aspirate during the procedure, and it's and then the needle can be held without movement, and that will be more comfortable for the patient. And then you can just put it, well, the needle is then pushed through once you're at the points in the vagina. You see where the insert the needle, and the needle is pushed through the second cover. And here in the 3-way cock have the syringe to aspirate, and you have another syringe where you can flush with sterile saline, and that's especially needed if it's more viscous, and to flush and then to aspirate to have a more complete aspiration of the abscess. And here you see, well, that's the way it is. You have the probe with the needle, then the syringe to aspirate, Lual syringe, of course, syringe for the flushing with saline, and of course you use your machine, and where you have this dotted line, that's the line where the needle will go through. Now, that's there is some discussion. What's better, to do a transvaginal aspiration with a needle, and then to pull out the needle and continue with the IV antibiotics and antibiotics, or to put a catheter, maybe a pigtail catheter, has the advantage that you can flush it with every 6 of 8 hours, but well, according of course to Seth Granberg and Gilland of the same group, they say that both are as effective, with very high success rate, above 90% for both procedures. Might be more difficult with putting a catheter, that an indwelling catheter is somewhat more difficult to insert. You need more material, and therefore it's more painful, and it's more difficult to do it in an outpatient setting. The catheter may come out and is more costly than just a needle. So cost is also an issue to consider when making your choice between the different procedures. When do you need surgery for, I mean, more surgery than just a drainage for tuber ovarian abscess? Well, and surgery may be a colpotomy, abdominal surgical drainage, adhesive lysis, unilateral or bilateral salpingo ovarectomy, or even total abdominal hysterectomy, and that's maybe needed when you have a rupture of abscess, certainly if it is bowel perforation, or if you have an unsuccessful drainage of a failure of treatment response. If you do a colpotomy, then well, we also use ultrasound to guide the surgeon to make the right incision, and not to go into the bowel or another structure that you don't want to go into. Usually then we guide the surgeon doing a transrectal ultrasound under GA to ascertain that you're on the right plane, and that you're that you don't perforate something else. Do you use do you use laparotomy or laparoscopy? I was teach long ago to do a big median laparotomy for those surgery for tuber ovarian abscess and extended PID. But nowadays, according to the skills you have, some will use laparoscopy. But whatever method you use, be aware that it's very difficult surgery. Everything sticks together, and there is a very high risk of bowel injury during the surgery. So you have to be an experienced surgeon to go into an abdomen with extreme extensive PID. So to conclude about PID and tuber ovarian abscess, what's needed for a proper diagnosis and for management? I think ultrasound has quite a central role in the diagnosis for PID, but also for tuber ovarian abscesses, and in the management of tuber ovarian abscesses. I think, as Sted Granberg and Gilland propose, is just to almost start with antibiotics and immediately with drainage if there is an abscess. And one of the arguments not to wait too long, not to wait for days and days with antibiotics before drainage, is that the fluid, the pus, becomes more and more viscous the longer you wait, and the more difficult it will be to drain the abscess if you wait too long. So of course, use ultrasound for the diagnosis and use ultrasound for the treatment, for the drainage of abscesses. Thank you.
Many thanks, Thierry. I think that's your last lecture now. So
I hope so.
I'm surprised you're not kind of reclining somewhere. I worked in Sweden with Seth Granberg, as you know, and Knut. I was always very impressed by his paper, and for a long time, hardly heard of people doing this, and I find it really surprising that the uptake of ultrasound guided aspiration was, I'm not sure actually is that great. And when you look at the papers that you cited, I mean, nobody's written anything about it really for 10 years plus. And he really has the only series, or quite big series, that I'm aware of. And I mean, why do you think that is? I mean, when you consider that surgical difficulty is actually pretty significant, and morbidity, and his results are so impressive, what's the story?
I don't know. I mean, first of all, I think he had quite many abscesses, perhaps because of the use of copper IUs. That's another thing. But I think I was trained with a do colpotomy, and that works also well. But I think the ultrasound guided drainage is more elegant. And now that we do more and more ultrasound guided puncture for biopsies and also for evacuations of cysts and abscesses, once you've done it, you realize that it's not so so difficult, and I think it makes sense. But I mean, his series is quite impressive. But indeed, he has I think the biggest series ever. I don't know. Perhaps it's not recorded. I think.
About 300 cases, isn't it, in his series? I mean, I don't know what was going on in that part of Norway, but there's an awful lot of abscesses going, so it's quite remarkable. I mean, so practically speaking, when you do this, do you give them antibiotics for a period of time before and see if they resolve, or do you intervene quite early and take the view that it's going to shorten the amount of time that they're, to recovery? What's your kind of? Do you have any criteria where you would say, look, that's bigger than X, I think we may as well get on with it, because otherwise we're just delaying the inevitable? I mean, how do you play it?
Classically, we thought to give for 48 hours antibiotics, and if it does not, if the clinical picture is not improving, then to go and to drain the abscess. But nowadays, I mean, well, Gilland just argues that you should do it immediately. But the longer you wait, you lose time, and because of the ease of the procedure, he does it quite
quite liberally.
Yes, but so and also nowadays with laparoscopy, I think the trend is also more to drain than not to drain, because then it's easy to do laparoscopy, or people are used to do laparoscopy and often do laparoscopy with patient with pain, and then see it, and then will drain it more commonly than before. When I was in South Africa, there was some, well, we had to wait for some 2 days or something, and we had quite strict criteria before doing an operation. But an operation meant a large laparotomy. So you have to weigh the
So I think what you're saying is that aspiration has become more common because laparoscopy has pushed things in that direction.
yes.
And so perhaps people, if you're going to do that, you may as well do aspiration. So it seems reasonable. Okay, final question. Does size matter? I'm not sure what we're talking about, whether there's a question here, whether it's an abscess or otherwise. I would argue that, I mean, obviously the bigger it is, the more likely you are to aspirate it. Thierry, thank you. We have to move on.
Thank you.
Very grateful to you. I know we've worked you very hard, but your talks have been fabulous. And you are, I think, now can retire to the bar or whatever you're going to go, or coffee or whatever else, and go and put your feet up. So thank you very much.
Okay, thanks a lot.
And I'll hand back to Igo, who's going to introduce our final speaker, if I may.
Yeah, thanks, Tom. Our final speaker for today is Regina Panliu. She's from the Philippines, an obstetrician gynecologist with special interest in OBGYN ultrasound. She does a lot of ultrasound management of gynecologic oncologies and female genital tract lesions, especially tuberculosis. That later aspect of it, genital tract tuberculosis, is what she'll be speaking to us today. An extremely important topic, especially for us working in the low and medium income countries. Welcome, Regina.
Good day, everyone. I believe this is the last lecture for today. But first of all, I would like to thank the organizers, ISUOG and FMF, particularly Professor Tom Bourne, for the invitation. It is always an honor to be part of this event. My topic is on the features and management of pelvic tuberculosis. I have no disclosures, and this is the outline of this lecture. The 2022 Global TB reports state that there is still an estimated 10 million people affected by tuberculosis each year, and remains to be one of the top infectious killers worldwide. It is mostly in the form of pulmonary TB, making about 82 to 85% of cases, and about 15 to 20% is infection of other organs, or what we call as extrapulmonary tuberculosis. Though this is only a fifth of the TB cases, the real challenge persists in the lack of clinical awareness and accurate diagnosis of extrapulmonary TB that includes female genital tract tuberculosis, which can have devastating clinical and reproductive consequences. Female genital tract TB, or the infection of the female genital tract, which is the focus of this lecture, is usually referred to as pelvic or abdominal pelvic TB, but appropriately should be termed female genital tract TB, with pelvic TB referring to infection of the lymph nodes. So female genital tract TB accounts for 5% of all female pelvic infections affecting women between the ages of 20 and 45 years of age. It is usually secondary to a reactivation of a pulmonary lesion, but may exist in the absence of pulmonary TB. It spreads primarily by a hematogenous route and affects every part of the female genital tract, favoring actually the fallopian tube. It is more prevalent in developing countries due to malnutrition and poor access to healthcare, and is typically seen in immunocompromised individuals. While pulmonary TB may be easily recognized because of the classic constitutional symptoms, these are usually not observed in female genital tract TB, since patients are mostly asymptomatic in 50 to 60% of cases, or it is just an incidental finding for infertility consults, particularly in developed countries. In the presence of symptoms, they exhibit features of organ dysfunction rather than infection. Thus, they may present with non-specific signs and symptoms like pelvic pain, vaginal bleeding, and abdominal enlargement, mimicking a broad list of differential diagnoses, usually PID and ovarian cancer and carcinomatosis. Thus, it is known as a great mimic. And further delay in diagnosis usually occurs because in 30 to 50% of cases, the physical examination is normal. Ultrasound, which is one of the most readily available imaging modalities, inexperienced hands may often help suspect genital tuberculosis. So let us look at the case of a 22-year-old multigravid who consulted for abdominal enlargement within 2 months after a spontaneous miscarriage. There was only occasional vague abdominal pain, and on physical examination, her abdomen was globular, doughy to touch, but was non-tender, and the corpus and adnexae could not be fully assessed due to the tense distension. So we did a transvaginal, a transabdominal ultrasound, and we can see on transvaginal ultrasound, an anteverted uterus, normal in size, but the endometrium was very irregular. There was ascites with fibrine formation and also a lattice-like formation, and there's the uniform thickening of the uterine serosa extending to the cul-de-sac, and we have a complex mass on the left adnexa, but on careful examination, we can see a normal ovarian stroma. So this must be the tube. And we have that lattice-like formation in the cul-de-sac because of fibrine formation. Actually, for this patient, there was bilateral complex adnexal mass. So on transabdominal ultrasound, there's the lattice-like formation. And then on transabdominal, again, the ascites, there's the thickening of the omentum, there's the fibrine formation, the fibrine stance, giving us the mobile septations, the subhepatic adhesions with the mobile septations, and the matting of bowel loops. So actually for this patient, this is usually the cases that we see which help us suspect genital TB. So we can see that usually they present with a combination of sonographic features, and each genital site will have its own sonographic spectrum. So the fallopian tubes are infected in 90% of cases being the first to be infected, and usually bilateral. Early disease may not show any abnormal sonographic features, but as the disease progresses, the tube increases in diameter and may present as exudative pyosalpingia similar to non-tuberculous PID, and there can be mild adhesions surrounding these masses. Unlike PID masses, Doppler usually does not exhibit so much flow, reflecting the caseous changes within these tubes. And the other form is the productive adhesive form, usually exhibiting thickened tubal walls and more extensive adhesions and fibrosis, such as in these 2 newly gravid patients complaining of chronic abdominal pain. In more chronic and advanced disease, they appear with intact fimbriated end, and we may be able to appreciate the tobacco pouch configuration associated with TB salpingitis. So these are examples grossly of tubes affected by genital TB. They have thick walls and are filled by caseous material. The ovaries are less frequently involved due to its tough capsule. So usually they can just present as a tubo-ovarian complex in periooperitis with discernible ovaries. But when there is already cacheating granuloma because of a hematogenous extension, the acnesa is just seen as a complex mass with no discernible ovarian stroma. But in the presence of these adnexal masses, plus the clinical presentation and the patient and in patients particularly in endemic region, we do suspect genital TB if they present with PID masses not responding to standard treatment, or they may present as bilateral complex adnexal masses with calcifications, which are actually attempts at healing with visible normal ovarian stroma, or in young adolescents with no coitarchy yet, but presenting with PID symptoms and with PID sonographic features. By direct drainage from the infected fallopian tube, the endometrium is infected in 50% of women, and the endometrium becomes irregular and advanced disease. In advanced disease, they may exhibit this pathognomonic moth-eaten or serrated pattern representing progressive erosion and deepening mucosal ulceration. This eventually leads to adhesion formation, calcification, and fibrosis, causing the patient to complain of hypomenorrhea, eventually amenorrhea, and infertility. But these features are only seen in about 2.5% of cases due to the cyclic shedding at menstruation that protects the uterine cavity from advanced TB infection. So most of the time, the endometrium may just appear normal with thin endometrium, particularly in the early phase of disease. But this will not rule out genital TB. We have to look for other sonographic features. With menopause, or delayed therapy, or in severely immunocompromised states, cacheation material and debris will continue to accumulate in the uterine cavity. So we have the appearance of pyometra or even as endometrial masses, which can be mistaken for endometrial carcinoma. As opposed to malignant endometrial masses, the TB endometritis rarely involves the myometrium and show no flow on Doppler studies since these are already necrotic tissues. With endometrial sampling, this will show the multinucleated Langhans-type giant cells that clinches the diagnosis of genital TB. And grossly here, we can see the caseous changes within the endometrium in a patient with pyometra and the myometrial extension of the cacheation necrosis, which is, as I mentioned, a rare event in female genital tract TB. When we do endometrial sampling, the best time to sample is during the premenstrual or late secretory phase, where the granulomas or acid-fast bacilli are expected to accumulate mostly on the top layer. Testing by menstrual discharge can also be done, which can also be done repeatedly, and usually is done during the day 2 of the menstrual cycle to improve diagnostic yield. TB of the cervix is rare. They present with similar symptoms like cervical carcinoma. There may be focal or diffuse lesions on ultrasound, but being accessible lesions, it is best diagnosed by doing a punch biopsy for histologic studies. The finding of concomitant TB peritonitis, such as in this case, usually increases the suspicion for genital tract TB, which usually is associated with genital tract TB in 50% of cases. It has variable disease presentation, and usually a vague and general abdominal pain is the most common presenting symptom. By ultrasound, ascites is a predominant sonographic feature and is present in about 70% of cases. And when we do examination of the fluid, usually it is exudative with a high protein content, lymphocytic predominance, but a very low yield of the acid-fast bacilli by smear or even by culture. It presents as 3 forms, and we have the wet ascitic as the most common with free ascites and fibrin formation and pseudocyst formation, and that characteristic uniform thickening of the uterine serosa and the posterior parietal peritoneum and the rest of the peritoneal layers, which we term as the pelvic blanket sign. And we can also have loculated ascites, which can be mistaken for an ovarian new growth. Notice the particulate ascites. So we just have to do careful examination to see if we really have a capsule for this. And this was in a 14-year-old newly gravid complaining for abdominal pain for the past 4 months. The fibrotic fix is characterized by omental thickening or caking and matted bowel loops and palisading of bowel loops with echogenic stipplings outlining the bowel serosa representing the tubercles. The dry adhesive is thought to be the healed fibrotic end result of the wet ascitic pattern and is characterized by caseous nodules, dense adhesions, and fibrosis. All these should be differentiated from carcinomatosis, which usually would present with irregular nodulations in the surface of the peritoneum. Grossly, the serosal and peritoneal surfaces are usually studied by millet seed-like lesions, which are actually the tubercles, which again would show the Langhans-type giant cells on histologic studies. Okay. So the gold standard in the diagnosis of genital TB is the isolation of the Mycobacterium tuberculosis, but due to the low yield and slow growth of the acid-fast bacilli by the WHO definition, a histologic evidence of cacheating granuloma on biopsy specimens, or in the absence of this microbiologic or histologic evidence, a strong clinical evidence consistent with an active disease is also acceptable. Still, other diagnostic modalities are exhausted to find evidence of the disease. So imaging modalities may help, but the absence of pulmonary TB on chest X-ray does not rule out genital TB. And there are usually overlapping of features. So we have, again, to do our careful history and physical examination. Ultrasound also may show overlapping features, but in the hands of sonologists familiar with the features, ultrasound is the useful modality. The newer molecular modalities have rapid determination for genital for the acid-fast bacilli, like polymerase chain reaction of Gene Expert. They are more promising, but they are more costly and have variable sensitivity for genital TB. Laparoscopy, on the other hand, may also be done, but usually this is quite invasive. Given the low sensitivity of the many diagnostic tests and the challenges of obtaining specimens, a composite reference standard is often used, but there are still no guidelines with regards to this. Silius recently compared the different diagnostic tests, and here you can see that polymerase chain reaction has been found to be the most sensitive technique for rapid detection of the Mycobacterium tuberculosis complex, particularly in these clinical conditions where it is a paucibacillary lesion. So practices actually may vary on healthcare and country settings regarding the diagnostic workups. In our institution, we do repeated body fluid sampling and tissue sampling when appropriate, and include diagnostic workup for extrapulmonary tuberculosis like chest X-ray, CT scan, and also ultrasound. And being a paucibacillary disease, as I've emphasized, the combination of tests will improve diagnostic accuracy. When confirmed based on tests or by strong clinical evidence of the presence of genital tract TB, the management is primarily medical, similar to that of pulmonary TB treatment. Surgery is reserved for persistent masses or for suspicions of malignancy or for drainage of abscesses. So we do start the patient on a total of 6 months of therapy, initially with 2 months intensive phase of quadruple therapy, followed by 4 months maintenance phase of 2 antibiotics with an additional 3rd antibiotic if the population is deemed to be resistant to isoniazid. In our setting, we usually extend our treatment to up to 12 months with a 10 months of maintenance phase because of recurrence. There are no specific recommendations regarding treatment monitoring, but treatment response is often based on clinical and laboratory assessment. In our institution, we recommend interval assessment of clinical and diagnostic labs and radiographic changes at 2 and 6 months, so we can decide whether to stop or to continue additional treatment for these patients. And on ultrasound, you usually may be able to see a decrease in ascites, resolution of adnexal masses, and thinning of the endometrium with completion of therapy. There may not be need to repeat laboratory tests, particularly if clinically the patient is improving, particularly if these tests are actually invasive. So this patient had, our index case had all acid fats bacilli samples diagnosed, but she had urine, stool, and sputum negative for AFB. Chest X-ray was also negative. Other tests were also not were negative. So she was started on empiric treatment. Her 2 weeks on treatment, and we can see a dramatic decrease in the ascites, and the adnexal masses are still seen, but there we can more delineate the ovarian stroma. So she's still ongoing treatment. So in summary, genital TB remains to be a diagnostic challenge. Index of suspicion is very important because they present symptoms and signs with overlapping of features with other diseases. Modalities are done to establish the diagnosis, and ultrasound may help, particularly if we are aware of the sonographic features. And medical management is the primary mode of treatment for 6 months, which is the standard treatment, to up to 12 months, depending on your situation. Thank you.
Thanks, Regina, for such a lucid lecture. I don't envy you. You had to do something extremely difficult, dealing with a condition that requires a high index of suspicion, really, and in which many of the diagnostic criteria seem to be non-specific. So it's nice, and thank you very much for the brilliant lecture. There's no question from the attendees here, but let's just ask, many of these cases obviously could come in as cases of infertility. What's the risk of diagnostic anything like the hysterosalpingography in these women?
I'm sorry, you mean the risk factors for these women?
In some of them are likely to come in as cases of infertility.
No.
So a HSG, yeah, if you were to do a HSG, what are the added risks for some of these women?
Yes, actually, in developed countries, patients come in for infertility. It's an incidental finding. but usually in our institution, they come in for pain or abdominal enlargement or an abdominal mass. It's a big pain. So we usually do not do the HSG because it's not, the workup is not targeted towards an infertility workup. So we just do the ultrasound, and then if we suspect it, we do the sampling for tissues and fluids for acid-fast bacilli. But in literature, actually HSG is being done, and it will show constrictions within the fallopian tube and even within the endometrial cavity. So it's just adhesions. As regards to spreading it with HSG, I was not able to read on that if it will worsen the situation, because we were just describing actually the radiographic findings when HSG was being done.
If we could extend that, what's the likelihood, what's the chance of infertility in many of these patients, even post-therapy?
Yes, because the target is usually the fallopian tubes. It's the first to be targeted, and the patients may just come in with adnexal masses. The endometrium may not be affected, but because the tubes are affected, in literature, about up to 19 to 20% pregnancy rate, but then the live pregnancy rate about 7% only. But most of these patients also 7%, and then most of them would have abortion, miscarriage. But as I've mentioned, because in our institution, actually most of our patients are multigravid. They come in already with previous pregnancies, although our younger patients are newly gravid, but infertility is not a problem.
Thanks, Regina. It's been a great time having you as one of our presenters today. So I know we're running short of time.
Thank you also.
Yeah, Tom, you want to round up? I know there are a few questions that have come in from the previous lectures.
Yes, indeed. Well, thank you, Aga, very much. I just want to add my thanks to you, Regina. It must be after midnight, I think, in the Philippines.
Yes,
right?
1 a.m.
So normally at this time you'd probably be out at a nightclub or dancing somewhere, I imagine. Is that right?
No.
No, no. I'm afraid I'm the same these days. My youth is behind me, very sadly. But anyway, listen, I'm very grateful for you for once again speaking at this meeting and doing so much for ISUOG. So thank you very much.
Thank you also for the invitation.
No, it's a great pleasure. Thank you for having us, for joining us. It's just my duty to finish off today, which is day one of Ultrasound Essentials. Please don't forget that we have another session starting in an hour, well, at 6 o'clock our time, so in 1 hour roughly, just under an hour, which is based around maternal mortality and morbidity. So it's kind of not ultrasound related. We've got fabulous speakers, Rubina Sahel, Christoph Lees, Abdul Sultan, we've got Theo Pepperer back, Ari Kumrasamy, Zahida Qureshi, talking about handheld ultrasound, PPH, sepsis, and so on. So that's tonight, and then obviously tomorrow we have a full day of obstetrics being run by Kypros Nikolaides and Leona Poon, running all day tomorrow. So hopefully you'll have a great day tomorrow. In terms of today, I think we've had a fantastic day. I'd like to thank everyone who's taken part in this last session. Aiga for being such a great co-chair. Thank you. Lovely to see you again. Judith Hearn always gives a great talk, and thank you, Judith. Emma, who was in the previous session, I see you're still online, so thank you to you. And Thierry, of course, 3 lectures. What a great effort. Thank you very much. The bottle of whatever you wish is on its way to Belgium. Thank you very much indeed. And then finally, because this is my last part of chairing, I just want to once again thank our sponsors, GE, who have been fantastic in sponsoring this event. Everyone in the office who've been running this, and of course the Be There Global team who've been running things as well. And all of you for listening. I think we've got almost 6,000 people registered. And I'm just thrilled that ISUOG is doing this for people in relatively low resource settings. It's what ISUOG should be doing. And I think it's reflected now in the costs of the educational courses as well. And I think it's important that ISUOG fulfills its charitable mission by doing exactly this sort of course and more. So I'm delighted that we're doing this, but it's hopefully a start. and we'll be seeing more of this type of meeting. And indeed, we've had a few hints today of things we should do around cervical cancer, for example, and things like that, where clearly there's a need. So thanks, everyone, and we'll hopefully see you all at 6 o'clock, or, roughly 50 minutes from now for the evening session, and for tomorrow for the obstetrics. And I'll see you all later. Thank you very much.